Well, thank you very much to the meeting organizers for the opportunity to be with you today. My name is Peter Grayson. I'm a rheumatologist, actually, not a hematologist, from the National Institutes of Health. And I guess we'll start with the pre-test question. Which of these is the most sensitive laboratory test to diagnose VEXAS syndrome? Absolute neutrophil count, mean corpuscular volume, platelet count, red blood cell distribution width, or hemoglobin to hematocrit ratio? All right, good. Well, for those of you that are even wondering what is VEXAS syndrome, maybe we'll start there too with the talk. I'm going to talk to you today about the discovery of a brand new disease that I'm sure many of you have heard about, and for those of you that are aware of it, I'm going to give you some updates on the latest research about it. And nothing brings this disease alive like hearing a case. So this is the first patient that we ever saw. This disease was discovered by a large group of investigators at the NIH, including my group, and my group focuses on vasculitis and inflammatory diseases. So in 2011, we heard about a man in his late 50s who previously was healthy and then developed a weird constellation of systemic inflammation, fever, orchitis, skin nodules, face swelling, DVTs, and he had inflammation of his ear. His doctors really had difficulty treating him with anything other than prednisone. And so he was referred to the Undiagnosed Disease Program at the NIH, and we saw him in consultation. And at the time we saw him, he told us something really radical. He said, I'm on 25 milligrams of prednisone a day. If you drop my dose by 5 milligrams within a day, I will flare. And we did that, and he developed skin vasculitis right in front of our eyes. His C-reactive protein rose, and we biopsied one of his skin lesions, and it showed medium vessel vasculitis. So we diagnosed him with an atypical form of polyarteritis nodosa. And when he was in the hospital flaring, you could see that picture of periorbital inflammation that he had been telling us about. Sorry, I think this is on a timer. Let me just go back. So he, from 2013 to 2017, really, his doctors had a difficult time treating him. They tried lots of different therapies. When they gave him a biologic therapy called anakinra, he had a horrific skin reaction, a vasculitic response. And he started to develop progressive bone marrow failure, which began first as a macrocytic anemia and then thrombocytopenia. His inflammation progressed. And finally, in 2017, we convinced the hematologist to do a bone marrow biopsy in him, concerned for myelodysplastic syndrome. At that point, he was requiring blood transfusions. And his marrow was hypercellular with a myeloid predominance. He had negative cytogenetic and genomic studies for MDS. And we were really stuck. You know, his hematologist said, get control of his inflammation and perhaps his marrow will improve. And the rheumatologist said, we're trying, but we don't really see this kind of marrow abnormalities in many of our patients. There's something, unusual, is something happening in the marrow. And we soldiered on. He got worse. He started to develop atypical mycobacterial infections that were disseminated. He was hospitalized many times. Now he needed platelet transfusions as his marrow was just failing. And in early 2020, he died from systemic complications of his disease. And I carried this case in my head for a while because the constellation of systemic vasculitis with progressive bone marrow failure was a grouping that I hadn't really been that familiar with or seen. And it was really just amazing how difficult his disease was to treat and how exquisitely sensitive he was to steroids. Above a certain threshold, he was okay. When you immediately dropped him lower, he got dramatically worse. And we saw 2 more cases exactly like him over the years. And so we sequenced these patients. We did whole exome sequencing of peripheral blood. We looked for some common genetic variant in the 3 cases that we had seen, and we found nothing. And then in the summer of 2019, a clinical fellow working in Dan Kastner's lab at the NIH named David Beck took a really orthogonal approach to disease discovery. Most of the time when we discover diseases, we look for similar cases, similar phenotype, or clustering of weird symptoms in one family. But David took a genotype first approach. At the NIH, we do whole exome sequencing on almost every patient that comes through, and we are accumulating these large databases of patient data, genetic data, in patients that are coming with undiagnosed conditions. And very rarely do we actually make a genetic diagnosis from these. So he had access to exome data from 2,560 people. He was very interested in the ubiquitin pathway because a lot of autoinflammatory diseases have been discovered by genetic perturbations in this pathway, so he restricted his search to 841 genes in that pathway. He applied a filter scheme. It had to be a total novel mutation, not reported in any human healthy database, and it had to be intolerant to haploinsufficiency, these things to make sure that it was likely a pathogenic variant. And from that scheme, he found 3 men that had missense mutations at codon 41 of a gene called UBA1. And these were the 3 men that we had seen clinically, like the first case I just told you about. And chromatograms of these men, which you'll see here, show something puzzling, which is this is codon 41, these are nucleotide peaks, and all of these men have a double read. And the UBA1 gene is an X-linked gene. These are men. So they have 1 allele, they should have a single read at each loci, and yet they have 2 reads. So after some genetic housekeeping, like excluding aneuploidy, we thought maybe this was likely hematologic mosaicism. Some of the cells in blood have this mutation and some don't. And so we biopsied skin and sequenced fibroblasts, and indeed what we saw is the double peak was only restricted to blood. It wasn't found in skin. So this is a mutation that's only found in blood and in bone marrow. And because these patients had progressive bone marrow failure, we took aspirates from marrow as well as peripheral blood, and we sorted and purified cell populations and sequenced each population, trying to figure out which cells have this UBA1 mutation and which don't. And so these are chromatograms from a single patient, and you'll see the red peak is wild type, so cells without the mutation, and the blue is the mutant peak. And if you look at the level of hematopoietic stem cells, there's equal red and blue peaks. Half of the cells in the marrow have the mutation, half don't. And when you chase this through myeloid lineages into circulating mature neutrophils and monocytes, it's almost entirely blue peak, no red. All of the neutrophils and monocytes in this patient has this mutation. But in contrast, going through the lymphoid progenitors and into mature T cells and B cells, all red, no blue. So none of these T cells or B cells in circulation have this mutation. So there's a mutation starting in the marrow and stem cells that becomes lineage restricted only to the myeloid cells. And this is another way to quantify that with the variant allele fraction. So skin fibroblasts, no mutation. T cells and B cells, no mutation. But the burden of mutation in myeloid populations is extraordinarily high. This is a very large clone. And then we started looking at the marrow of these patients. And Kathy Calvo, who's a hematopathologist at the NIH, was really amazed because in the first 3 patients, they had this very striking characteristic finding. In their erythroid and myeloid precursor cells, they all had these vacuoles, these little white dots throughout the cytoplasm of the cell. This has become a very sensitive finding for this new disease, VEXAS syndrome, but not every patient will have it. And as you know, it's not a fully specific finding because things like copper deficiency are associated with the same phenomena. This is a mutation that is lineage restricted to myeloid cells. And so here you can see a bone marrow derived monocyte from a healthy patient and then from a patient with one of these UBA1 mutations. This is a toxic mutation. And when you do RNA sequencing of myeloid versus lymphoid cells, you see severe hyperinflammation in these patients, upregulation of any of your favorite innate cytokines, IL-1, IL-6, TNF, type 1 and type 2 interferons. It's why this disease is so difficult to treat. They're in a state of myeloid hyperinflammation. And so what is UBA1? Well, it's actually a gene in the ubiquitin pathway, as I mentioned. There's 3 steps to ubiquitination. The ubiquitination is a fundamental process in a cell because it affects cell signaling, it affects protein localization, and most importantly, it affects protein degradation through the proteasome. And it's done in 3 steps. There's an E1, E2, and E3 step. The E3 enzymes, there's over 600 of these, and this is where a lot of genetic diseases have been discovered. It's why we focused on this pathway. If you go to E2, it's less specific. But E1, there's really only two, UBA1 and UBA6, and by far and away, UBA1 does 99% of the work. So we're describing here a somatic mutation, an acquired mutation in the master enzyme of all of cellular ubiquination. It's why this is only a somatic disease. If this were in the germline, it would be lethal. And we named this disease VEXAS syndrome, and these are the salient clinical features. It's an acronym. V stands for vacuoles, those vacuoles that we see in the marrow. E1 enzyme is the UBA1 gene. X-linked, as I mentioned, it produces autoinflammation restricted to myeloid cells, and it's a somatic mutation. And these patients get profound inflammation in their lungs, in their skin, in their cartilage, and in their marrow. So how do you recognize this disease? Well, the first thing is it's a disease of older men. Again, it's a X-linked recessive disease. And the first 25 patients that we described in the New England Journal of Medicine, the median age at onset was 64. The youngest patient we've ever seen with the onset of symptoms was 45. 100% male, although that's not true anymore. We've seen women with monosomy of the X have it, and now we've even seen euploid females have it. And amongst rheumatologists and hematologists, this is where it got exciting for us, because these patients actually met clinical or diagnostic criteria for a range of different rheumatologic diseases and hematologic diseases. This was really a disease that is bridging rheumatology and hematology. These patients were diagnosed with relapsing polychondritis because of their ear cartilage inflammation. With Sweet syndrome, they get granulomatous inflammation in skin. Myelodysplastic syndrome, a few of these patients will evolve into a multiple myeloma, which we think is an off-target effect. Polyarteritis nodosa, giant cell arteritis, various forms of vasculitis. And this is a picture of the VEXAS man. I say man because it's almost always men. And you can see they get fever, they can get inflammation in various structures in the head and neck, the lungs, the gut, all this bone marrow pathology. They get inflammatory arthritis, they get a whole range of skin disease, and a very high rate of thromboembolic disease, over 40% of these patients, with both arterial and venous clots. This is a clotting disease that's more potent than even Behçet's disease. And we recently completed a genomic ascertainment study using data collected in the community in Pennsylvania. And our prevalence estimates from that study is that this is a disease that's found in 1 in 14,000 individuals. To put that in perspective, that is the exact same prevalence of all of MDS. And in men older than 50, it's 1 in 4,000, 1 in 5,000 men. This disease is everywhere. It's just we haven't been seeing it. It's hiding in plain sight, and it's being dispersed across many different subspecialty physicians. And we've known a long time about this overlap between myelodysplastic syndrome and inflammation. And I think this disease is teaching us that we need to be doing this in a more substantive way. I bet you in your MDS clinics, if you unleash a rheumatologist in there, that person will start making a lot of diagnoses for you in that clinic. And it also is telling us that we need to be expanding what we're thinking about beyond these small list of genes that are classically associated with MDS. UBA1 was not on that list. It should be. And I'm sure there are others. And we are getting patients referred to us with these kinds of phenotypes. And originally our hit rate was about 50% of them were positive for UBA1 mutations. Now it's down to around 30%. And we're describing these VEXAS-like conditions. I'm sure there are new genes to be discovered in these populations. And it's easy to see. So this is an algorithm we developed. We have a relapsing polychondritis cohort at the NIH. And so this is specific to them, but it probably is generalizable. So in a patient who has ear or nose chondritis, you can tell if they have VEXAS with 3 very simple clinical variables. Is the patient male? And if so, does the patient have an MCV greater than 100, which almost every patient with VEXAS does, or a platelet count of less than 200? And I'm sure this is kind of the same for any patient with severe inflammation that's difficult to treat, not just ear or nose chondritis. And really, it's the MCV that's the key. Almost every patient, unless they have concomitant iron deficiency, has a macrocytosis. An elevated MCV in an adult patient, particularly a male, with inflammation involving skin, cartilage, or lungs should trigger genetic testing for VEXAS. Okay, I'll briefly go through the mechanisms of disease, and I just want to highlight a few things. This is the typical classic VEXAS patient, at least as we see them through rheumatology. I think you guys will start to see them in a slightly different way. They generally present with inflammation, often in the skin, recurrent vasculitic rash, neutrophilic dermatosis, this kind of thing. They develop macrocytosis early, often when they're, so we're trying to teach the dermatologist inflammation in skin plus elevated MCV. We need to think about this disease. Then they develop a macrocytic anemia. In this particular patient, you can see the anemia progressing. By 5 years into disease course, they were red blood cell transfusion dependent. And by 6 years, they finally met diagnostic criteria for low-risk MDS. And this is the platelet count declining over time. These green arrows are multiple biopsies, bone marrow biopsies that the patient had, where you see hypercellular marrow, those abnormal vacuolated myeloid cells. And so in some ways, this is a pre-MDS condition, and there's a lot of discussion of whether this should be considered an MDS or how we should classify this disease. Almost every one of the patients has a mutation only at codon 41. This is a mutational hotspot in the disease. So what's happening? Well, there's two isoforms of UBA1, a long isoform that's translated from codon 1 that's in the nucleus, and a short isoform that's cytoplasmic that's translated at codon 41 where these mutations occur. And the net result is, instead of this normal UBA1A and 1B, the two isoforms, you don't produce normal amounts of UBA1B because the mutation's there, and you create a new inactive isoform that we call UBA1C. And it goes a little bit deeper than that. Actually, there are 3 amino acid substitutions at codon 41 that define most of this disease, where the methionine becomes either a valine, a leucine, or a threonine, and these have prognostic importance. So the patients that have the valine mutation translate the least amount of functional UBA1B, the cytoplasmic isoform, and they die the fastest. So in red, these are survival curves. Patients with the valine variant, no patient in our cohort has survived longer than 12 years after symptom onset. 25% of our cohort has died from this disease. It's a highly lethal disease, median survival around 10 years. But the leucines and the threonines do a little bit better, and the leucines tend to have more skin disease and more hematologic involvement. It's likely through hematology referrals that we see more leucine variants, and through rheumatology referrals we see more valine variants. We've had not a lot of success treating this with anything other than steroids. We're looking for drugs, but there have been reports emerging of successful hematopoietic stem cell transplantation, and we have a protocol ongoing at the NIH to transplant these patients for research. There's a lot of discussion about how do we classify this disease. ICC and WHO recently said this is a clonocytopenia of undetermined significance. I know that's by marrow, but at least by clinically, it's pretty certain what the significance is, and it's not good. The International Consensus Classification of Myeloid Neoplasms and Acute Leukemia says this is a pre-malignant clonocytopenia. We think of this as a brand new class of disease, and we are calling this a hemato-inflammatory disease, a disease defined by hematologic mosaicism, systemic inflammation, with a propensity to become a myeloproliferative, myelodysplastic, or lymphoproliferative disease. And I think there's other examples in medicine of what we would consider to be hemato-inflammatory diseases, Erdheim-Chester disease being a good one. So VEXAS is an overlap disease with severe inflammation and bone marrow failure. It's caused by acquired mutations in UBA1 and bone marrow stem cells. The elevated MCV is the key clue to spot the disease by blood tests. It's a prototype for a new disease paradigm whereby somatic mutations in blood and solid organs may underlie adult-onset rheumatologic diseases, which is why it's been really exciting to rheumatologists. We're always late to the game. You guys talk about, molecular diagnostics, and you're very familiar with the concept of somatic mutations in cancer paradigms. Rheumatologists, we're not. We still think about germline genetics only. And so I think this is really letting us figure out, this is a clue to how we find diseases that start later in life within rheumatology. And we'll go back to the post-test question. Awesome.
Very well done.
Good job.
Later.
Okay.
No.
Maybe one question.
Well, maybe one quick question. We are still behind, but we gained a little bit of minutes. So if someone has a quick question. Can we have a microphone here?
Good morning. Gus Fonseca, Florida cancer specialist in Florida. You described this as a very lethal disease. About, I think, the valine mutated folks had a mortality in the 10 years of median. So what do they die of?
They die of many different things. Because the mutation is toxic to marrow and it's not tolerated by lymphoid lineages, they are profoundly lymphopenic. So they get a wide range of opportunistic infections. It functions as like a functional immunodeficiency. They have a ton of thromboembolic events and clotting diseases. They ultimately have progressive bone marrow failure and become very transfusion dependent and all the problems inherent to that. They have very high and escalating steroid requirements, so then they have all of the side effects and long-term problems of chronic glucocorticoid use, and then they have bad systemic inflammation that's hard to control. So they die of an entire range of spectrum of possibilities, unfortunately.
Thank you.
Thank you.
Thank you very much.